All right, guys, we're going to take a look at Chapter 8 in the Human Anatomy and Physiology book by Marieb and Hoehn. I've got my AC running, so hopefully you can't hear that in the background. It's hot, so apologies in advance. Anyway, so let's take a look. This chapter, we're going to be talking about joints. So skeletal articulations are any place that two bones come together and articulate or touch. And there can be movement occurring at those joints, or there may not be movement occurring at those joints. So we're going to, in this little first section here, define a joint. An articulation is another term. We've kind of already have defined a joint. It's where two bones come together and articulate with one another. We're going to classify joints based on their structure and their function. Structure just means, what are they made out of? What are some structural characteristics of the joint that might make it fit into a certain category? And then we also look at their function, which in the case of joints, we're just really talking about how much movement occurs at the joints. And then we're just going to look at some general structures of some various joint types. So let's jump into the classifications. There's two categories or two classification systems. The first is based on the amount of movement allowed at a joint, which is called the functional classification. And then the second is based on the composition of the joint, which is called the structural classification. So let's start off with functional. There are three functional joint categories: synarthroses. You can also say it's a synarthrodial joint or synarthrosis, amphiarthroses, and diarthroses. Synarthroses allow essentially no movement. Amphiarthroses allow very little movement, and diarthroses allow the most amount of movement of any of these three categories. I'm trying to think if there's anything else I want to say here. One thing to just add is diarthroses dominate the limbs. The joints of our limbs tend to be very mobile, whereas the joints of our axial skeleton have a tendency to be less mobile, in our skull especially. So let's look at the structural classification. So we have three categories here. Fibrous joints are joints held in place by fibrous connective tissue or fibrous ligaments, which is also connective tissue, but basically two bones, typically highly congruent, held in place by fibrous connective tissue. The next category is cartilaginous joints. The name's pretty explanatory there, just like the previous one. These are joints held in place by cartilage. And then lastly, we have synovial joints. Most of this lecture will be about synovial joints. So we're going to have many slides on those. So let's just start off with these first two categories. Firstly, fibrous joints, three types: sutures, syndesmoses, and gomphoses. This first picture here is a picture. It looks like potentially, most likely, we have the coronal suture with the sagittal suture behind it. I guess it kind of could be like an upside down lambdoidal suture and parietal suture, but I think it's coronal and sagittal. And the point here, what I want you to see is that this joint is highly congruent, which means there's a lot of surface area contact between the two joints. And that's really true for all these joints. If you look at the tooth, and then this one less so, syndesmosis, but they're highly congruent joints. And then in the body, they're basically cemented in place by fibrous connective tissue. But these joints as a category allow very little to no movement and are all synarthroses, potentially with the exception of the syndesmoses. I apologize. I don't know what anatomists and kinesiologists are if they're referring to syndesmoses now as amphiarthrodial or synarthrodial. So I won't ask you that on a quiz, but just know that the fibrous joint category as a whole allows the least amount of movement of any structural joint classification. So here's the suture. Here's the syndesmoses. If we were defining these differently, the difference would probably be that a syndesmosis utilizes a relatively long fibrous ligament compared to these other two joint types. This is just going to be plastered in fibrous connective tissue. It's not really a ligament. This has a very small, short ligament holding the tooth in place. This is a gomphosis. And then this has, compared to the other two, a relatively long ligament. And this is just a distal tibiofibular joint held in place by an anterior tib-fib and posterior tib-fib ligament. So these are all joints held in place by fibrous connective tissue, and they allow very little movement, which makes sense, right? You don't want your teeth wiggling and you don't want your sutures wiggling. If your sutures are wiggling, you're having a pretty bad day. So let's go to cartilaginous joints. So two types, synchondroses and symphyses. Synchondroses are held in place by hyaline cartilage. So this first one here is an example. It's a joint between the epiphysis and the diaphysis. So that is indeed a joint, and it's hyaline cartilage. Here's another example. These joints between the ribs and the sternum are composed of hyaline cartilage. It allows some movement, but very little. They're definitely not diarthrodial. This would certainly be a synarthroidal synchondroses. This, I believe, would as well. Then we can look at a symphysis. A symphysis is a joint. It is composed of hyaline cartilage, but the difference is that there's a fibrocartilage disc in between the two articular surfaces. So one example would be your pubic symphysis, and another example here would be your intervertebral discs. And these allow a bit more movement, so these would be amphiarthrodial joints. And then here's where we get into the synovial joint. I'm actually going to draw a picture in a little bit of a synovial joint. The main thing for this slide is just to make sure you guys know that the number one distinguishing feature of a synovial joint is the presence of I guess I could have typed. It's harder than it looks. Is a joint cavity. Yes, that says joint cavity. Man, I look like I flunked kindergarten. I need to go back. Anyway, so there's a hollow joint cavity filled with synovial fluid, and we're going to talk all about that in a couple slides. So what's the synonym for joint? Articulation is a synonym for joint. Which functional joint class contains the least mobile joints? That would be synarthroidal joints, because it says functional. If it's a structural joint class, which structural joint class contains the least mobile joints? You would say fibrous. Of sutures, symphyses, and synchondroses, which are cartilaginous? A suture is not. That's a fibrous joint. Symphyses and synchondroses are cartilaginous. And now we didn't answer this next question, but I think it's kind of intuitive. How is joint mobility and stability? Oh boy, guys, I'm sorry, I'm yawning. I hope I didn't make you yawn. That's a bad sign if I'm yawning. It's late. So how are they related? If I was going to sum it up in one word, I would say inversely. The more, and it makes sense, the more stable a joint, like picture a suture of your skull. Well, that's not going to be very mobile. And the more mobile a joint, like if you think of your shoulder, for example, well, it's inherently less stable. It's still stable. It's not like your shoulder's falling out left and right. But when compared to your suture, it's much less stable. So, I mean, you've heard of people dislocating their shoulder, and it's, a fairly common thing. You don't typically hear about people dislocating their suture. Number one, because that would be, fatal if you were dislocating a suture. But number two, because it just doesn't happen nearly as much. It takes a lot more force to do something like that. So mobility and stability are inversely related. Okay, so let's dive into synovial joints. I'm going to take a big risk here. So this is admittedly probably a huge mistake, but I'm going to draw the knee joint. I'm going to do my best. So there's a little tib tube with an anterior border, and then the back of the tibia. Not a bad tibia, it's a side view. And then we're going to draw in some femoral condyles. Kind of made those condyles a little small, but that's okay. Whoa, became a fat femur on accident. And then we've got a patella here. There you go. There's a lateral view of your, oh, you're going to think that means left because it's a right knee. It's a right knee, but it's a lateral view. The tibia would be in here as well, but we don't have time for that. So then let's add in some articular cartilage. The portion of the bone that actually makes contact with the other bone is always going to be covered in hyaline cartilage. And that's sometimes just called articular cartilage for short, but it's always hyaline. There'd be some on the patella as well, but we're not really going to talk about that joint. So there's always articular cartilage. Then we have a joint cavity, but you can't have a joint cavity with a joint capsule. So let's draw the joint capsule first. The joint capsule actually has two pieces, two components. So we'll do this dot is going to be for the fibrous joint capsule. So the fibrous joint capsule, we're just going to ignore the patella, keep it simple. So this will be the tibiofemoral joint that we're drawing. So the fibrous joint capsule is in orange. And then in blue, let's do the synovial membrane. So you might need to add those words in. I said might. What I meant was you need you need to add those words in, sorry. So there's the synovial membrane. Boom. And the synovial membrane, its job is to produce synovial fluid. And synovial fluid kind of has a consistency of, I'm just going to draw little X's, I guess, of egg white, like uncooked egg white, if you can picture that. So that's where its name comes from. It has the root word ovum for egg, and it's synovial fluid. It's a blood filtrate, just like sweat or urine. It resembles blood plasma chemically, a little different, but it's produced by the synovial membrane. Everything inside the joint capsule is covered in synovial membrane. So let me draw this a little differently, actually, so I have more room. Let me draw the tibia like down here. That's not as pretty as a tibia, oh boy. So I need to move my articular cartilage. Oh, come on. Okay, so there's my articular cartilage. So let's say we had a ligament inside the joint capsule, which would be the case in the knee, actually. You have two intracapsular ligaments. So let's draw one right here. That's a ligament. Now, that ligament is inside the joint capsule. So everything inside the joint capsule, with the exception of the articular cartilage, is covered in synovial membrane. Why will it not listen to my color selection? Okay. So there is, oh boy, I'm trying to draw it on the outside of the black line. That's synovial membrane. Everything in the joint capsule, except for the articular cartilage, is covered in synovial membrane. And that synovial membrane is producing synovial fluid. Which brings us to our next, oh my goodness, I'm so sorry, you guys. That brings us to the reinforcing ligament section. So there's a few different types. I'm not going to write them, but you can. The first is intracapsular, which we just drew. It's a ligament inside the capsule. I use black for intracapsular. Let's use green, I guess, for extracapsular. So there can be a ligament outside the capsule. Isn't that pretty? And then there's capsular ligaments, which I'm not going to draw because it's would be tough to draw, but this is a thickening of the joint capsule itself, which I drew in orange here. So if one part of this joint capsule in a particular area is really thick and well defined so that it almost is its own ligament within the capsule, we would call that a capsular ligament. And then of course they have nerves and blood vessels, fat pads, and menisci. Fat pad's just what it sounds like, a pad of fat to protect something. There's some around your patella to sort of protect the various structures around your knee. And then menisci. Meniscus is a fibrocartilage disc. And it just so happens that you have two in your knee. And so it just kind of is sitting in here like this. Little shock absorber. Another better way to draw it for the knee in particular would be to draw a top view. Okay, so this would be a right knee superior view. And then we have our intercondylar eminence. And then you have your big C-shaped medial meniscus, and then a smaller O-shaped lateral meniscus. You don't need to draw this here, but just an example of a meniscus. And you have menisci in other places, your AC joint, your temporomandibular joint. There's an obvious one I'm forgetting. Your pubic symphysis has a fibrocartilage disc. I think even some of your metacarpophalangeal joints might have it. Anyway, there's a few examples of that. And then another structure that's found often in and around synovial joints are bursae and tendon sheaths. So picture a sphere. I know it's a circle, but pretend it's a sphere. Don't ask me to draw a sphere on here with these little pins. Okay, so here it is, and it's lined with synovial membrane. So that synovial membrane is producing synovial fluid, so it's a ball of synovial fluid. Now imagine that same structure, but we squish it a little bit. So now it's like a pancake. It's still lined with synovial membrane, and it almost becomes this little protective cushion slash friction reducing rolling bearing idea. And you see these anywhere where there's something delicate that needs to be protected. So for example, this is your greater trochanteric bursa. If you touch your greater trochanter, which you can feel fairly easily on your kind of proximal lateral thigh, you can feel your greater trochanter. It's not that deep below your skin. You know, there's only maybe a ½ inch of tissue between that sharp, big, bony prominence in your skin. You need something there to protect your skin and the muscles around it. So the bursa is an example of, or the bursa does that. You see one here, your iliopectineal bursa in front of your femoral head. You have an ischial bursa because you sit on your ischial tuberosity and you don't want that bone cutting into your glutes and your skin, right? So you need this kind of friction reducing cushion, and the bursa does that. Now, the tenant sheath is technically anatomically the same thing, but it's stretched out a little bit and wrapped around a tendon, so it is a little different. So now picture that sphere and picture squishing it like a pancake, but now it's nice and long. It's like a hot dog. And it's still lined with synovial membrane, just like a bursa. But now we put a tendon that is supposed to be a straight, beautiful tendon. Oh gosh, it just went bad. And then picture folding this tendon sheath around the tendon, like a burrito or a hot dog or something, and you get something that kind of looks like this. Here's a tendon wrapped in a tendon sheath. This allows the tendon to slide back and forth through here without rubbing against a ligament or a bone, and it keeps the tendon safe. It protects it and reduces friction. If you've ever heard of tendinitis, that's actually an inflammation of the tendon sheath, not the tendon itself, but the tendon sheath. This structure, just like bursitis, is inflammation of a bursa. Anyway, takeaway from this slide is that these two structures serve to reduce friction. That is how they improve joint performance, by reducing friction. All right, so what influences joint stability then? Well, three things. This really should say congruency of articular surfaces. So how well do the articular surfaces fit together? The amount and strength and orientation of the ligaments, and the amount of muscle tone. Surprisingly, muscle tone is the most important. It probably wouldn't seem that way. It's really easy to see, though, if you work with someone who's had a stroke, particularly a middle cerebral artery stroke, which affects the arm, and so the person's arm becomes paralyzed and flaccid. You'll typically see their arm in a sling or in a trough in a wheelchair, and the reason that is because without muscle tone, the head of the humerus will just, over time, just fall out of the glenoid fossa and sublux, which is a partial dislocation. Okay, so muscle tone is crucially important because muscles don't stretch out. They're under tension. They maintain force. Ligaments will stretch out if under a constant pressure. They're good at resisting sudden, strong jolts. That's why they have a tendency to tear during really traumatic injuries. What they do not do is sustained force. If that muscle tone goes away, like with a stroke, they just stretch out over time and sublux. And articular surfaces is hugely important, but it alone really does nothing. The femur and the acetabulum are the two of the most congruent articular surfaces in your entire body, but you go into the anatomy lab and put them together, and they're just going to fall right apart, right, without muscle tone and ligament. So very important, but relies, we rely heavily on muscle tone. So again, all these are three factors that influence joint stability. Articular surface just refers to how well the joint fits together. So let's say we're talking about our humerus, and then a relatively small glenoid fossa. Here's a scapula, right? That is not that congruent. It's actually fairly congruent compared to most joints, but compared to the hip is highly congruent. So here's our femur. Head of the femur. The acetabulum, including the labrum, comes like way to the, past the equator almost of the femoral head. So it's a very congruent, very stable joint. Add to that the fact that there's ligaments all over the place, just crisscrossing, and it's actually pretty impressive. When we get to the hip, you'll see, and not to mention massive muscle groups. The hip has all of it. So the biggest muscles, the biggest ligaments, the most congruent joint surfaces. Anyway, I got crazy there, sorry. So, test question, muscle tone is the biggest contributor, but they're all important. Check your understanding. I mentioned this briefly. What are the two layers? The fibrous joint capsule, which is lined by the synovial membrane. Together, those are called the articular capsule. How do bursae and tenant sheaths improve joint function? By reducing friction. Which factor is most important in stabilizing synovial joints? Muscle tone? Oh boy. This is why I put this in here now, because I always forget stuff. What is the importance of weeping lubrication? So picture your knee again, right? So here's your knee. Okay, and now imagine walking. There's a period during gait where all of your weight's on one leg. And not only is it on one leg, but you're actually subtly flexing or extending your leg with all of your weight on it. So just imagine these two bones being crushed together. And here's their cartilage. They're just being crushed together under full force while bending. Compression alone is not that bad, but compression plus shear is a good way to rip cartilage. So these big weight-bearing joints like this, when they're not under pressure, they actually absorb a little synovial fluid. So then when you put them under compression, a little synovial fluid leaks out. So now they're under compression, they're shearing, but there's some lubrication in between the two joint surfaces, which really reduces friction, reduces heat, and reduces damage. So that's the importance of weeping lubrication. Reduce friction, reduce heat, reduce damage in weight-bearing joints. Okay, we kind of flew through this first part so that we could get to this part and slow down a little bit, because this is where it gets real, where the wheat is separated from the chaff, where the men are separated from the boys. It's not really that confusing, but we have an extra layer of it being confusing since we're not in person. So I will do my best here. So this first idea is just distinguishing between a muscle origin versus a muscle insertion. These are both muscle attachments. And I'm trying to think of a good example of one that's easy to draw. I can't think of an easy one, so I'm just going to draw one. Let's draw the humerus. I'm drawing a little short, ugly humerus, sorry. And then, so the ulna would be down here somewhere. And there's the ulna. And then the radius. Oh boy, this is not my best work. And then there's a radial tuberosity right there. I kind of cut the bottom of it off. So now picture we've got, this big, where's red? We've got this big biceps muscle here. It's made of two heads. and then it has a tendon that inserts on the radial tuberosity, and then it has two tendons up here. This was the worst muscle I could pick, I'm sorry. And here's, let's say the coracoid process is right there. So one of the tendons connects over there, I believe, and one of them connects up above the glenoid fossa. So anyway, two muscle attachments up here, one down here. So how do we know which one is which? What's the origin? What's the insertion? Well, I'll tell you. That'll make it easy. This is the insertion. These are the origin. What makes these the origin and what makes these the insertion? Well, the definition of the origin is that it's the more proximal and less mobile muscle attachment. More proximal, which is the case here, it's closer to midline, it's closer to center mass, closer to the thorax, so it is more proximal. This is more distal because it's further down the extremity, closer to your hand. How do we know which one's more mobile? Well, this is, it's always based on this idea called open chain. And this is going to get extra confusing, and I apologize. But imagine doing a bicep curl. Your hand is moving through the air, your elbow is flexing. This structure here is moving, the radial tuberosity, the insertion is moving, but the origin is not moving because your shoulder is not going anywhere, it's just your hand that's moving, you're bending your elbow. So that makes this a more mobile muscle attachment. Contrast that motion with a chin-up. A chin-up is the exact same thing. You're bending your elbow, except now instead of your hand moving through the air, you're actually lifting yourself up off the ground. But still what you're doing is you're bending your elbow. Now your hand is fixed on a solid object, which is the chin-up bar, but your body isn't. You could lift yourself up. That's called closed chain. When you're fixing the distal end of your extremity, that's closed chain. So origin versus insertion is based on open chain. So if our hand is free to move around, which of these two attachments is more mobile? Well, it's this one. It's the insertion, the radial tuberosity, which is why we call it the insertion. So anyway, the point is, if that was confusing, don't worry about it. Origins are more proximal, less mobile. Insertions are more distal, more mobile. I won't ask too many questions about that, but it's in your book, so I just wanted to cover it real quick. So we're going to talk about all this different stuff here. We're going to talk about non-axial movement, which isn't too exciting. We won't cover that much. Uniaxial movement is just a joint that moves around one axis. Biaxial movement occurs in joints where the joint can move around two axes. And a multi-axial joint is three or more axes that the joint can perform a motion around. So let's look at those now. Let's start with gliding. All right, gliding. Gliding, unfortunately, is not too terribly exciting. It's basically just two bones sliding past one another. It's a non-axial movement since there's no rotation. It's not an angular movement like the other movements we will be talking about. That said, it is very important. We probably underestimate the importance of this minimal amount of gliding in our tarsals and our carpals and various other bones. We just aren't going to spend much time talking about it. So let's go on to angular movements. So angular movements occur in synovial joints. These type of movements allow very large amounts of movement, and the movement occurs around a particular axis and within a particular plane. So you can see here there's three pairs of motions: flexion and extension, right here, abduction and adduction, and horizontal abduction and adduction. Really quickly, I want to run through the axes that belong to each and the plane that belongs to each, and then I'm going to come back through and try to explain that. So for flexion and extension of any joint occurs in the sagittal plane. Now there's one exception for all of these, which is your thumb, but let's just ignore our thumb for today, and then we can say that flexion and extension always occurs in the sagittal plane. It's that simple. And it occurs around a medial lateral axis. Abduction and adduction always occurs in the frontal plane. Again, except for the thumb. But it always occurs in the frontal plane around an anterior posterior axis, and horizontal ab and adduction occurs in the transverse plane around a superior inferior axis. Sorry, hopefully I can find that and edit it out. So anyway, so hopefully you wrote that down, and now let's run through it. So flexion and extension. Let's think of your humerus from like a lateral. Oops, it's a skinny humerus from a lateral view. So here's your olecranon. There's your ulna. Right. Okay. So there's your humerus and ulna. So that's your elbow. This motion here, you would agree that it's decreasing this angle. So this angle is like what, 160 degrees maybe? Right here, that angle. This motion here would be decreasing the angle. That's called flexion. And then as we bring it back the other direction and we increase the angle, that's called extension. So picture a bicep curl as flexion and extension. And that's actually the only pair of motions your elbow can do, is flexion and extension. Now I want you to picture your forearm moving up and down. Your upper arm isn't going anywhere, you're just bending your elbow. Oh boy, this is going to be risky. Using a stick figure. Okay, that's a hand there. Do not show this to anyone. Promise me. So here's your elbow here, right? And your elbow is going up and down. Except, I can't draw it 3D. So your hand would be coming straight towards you as you lift, and then falling down as you relax. Anyway, the point of drawing this terrible drawing was to just remind you that this is the sagittal plane, but the sagittal plane doesn't necessarily have to be dead center. You can have a sagittal plane here. The point is it's a plane dividing your body into a left and right component. So your forearm, when you're doing a bicep curl, is moving through the sagittal plane during both flexion and extension. Okay, so we call both these movements here sagittal plane movements. And they occur around a medial lateral axis. Now what that means again, oh boy, why did I erase my stick figure? Well, here's your arm. So here's your arm. Here's your hand. And here's your elbow. Your elbow is rotating around this axis when you flex and extend it. Okay, here you are. Here's your person, your two arms, your legs. You're looking at us. You're so happy to be in anatomy class. Okay, there you are. So your elbow is rotating around this axis, which is the lateral medial axis. Right? It's not superior inferior like this. It's lateral medial. So your olecranon is spinning around the trochlea, which is a lateral medial axis when you do elbow flexion. That's going to be true for flexion of any joint, shoulder flexion, knee flexion, hip flexion. The motion's occurring around a medial lateral axis in the sagittal plane. Now let's talk about abduction adduction. If any of you had the misfortune, no, it's actually beautiful out there, but the misfortune of growing up like in the Midwest or anywhere else cold. I grew up in Michigan, so I know cold. You may have made a snow angel, or maybe you've at least seen one on TV. Well, a snow angel is like the perfect example of abduction and adduction. So we're talking in this picture about shoulder abduction and adduction. So lifting your arm up, in this case, away from midline is abduction because you're abducting the limb away from the midline. And then bringing it back down is adduction. You're adding it back to midline. This activity, whether it's of your shoulder or your hip or your fingers, is a frontal plane activity. The motion occurs in the frontal plane. It also occurs around a it occurs around an anterior posterior axis. All right, and then lastly, we have horizontal abduction and adduction. Now it's kind of tough for me to draw it this way actually, so I'm going to have to do a superior view. So here is your head, and here's your nose. Oops, I gave him kind of a big nose. I feel bad. And then here are his arms sticking straight out like a scarecrow with his fingers. It's all in the detail, you guys. That's why I'm such a good artist. Bringing his hands in like that to say this position, he just performed horizontal adduction because he's bringing his limb towards midline. Okay, that's horizontal adduction. And then bringing it back to baseline here is horizontal abduction because he's taking it away from midline. That activity occurs in the transverse plane and occurs around a superior-inferior axis. Now, I'm going to show you something. I haven't decided if it's helpful yet or not, but I think the axis idea confuses people. So I kind of like to use an analogy. So pretend we're looking straight at a car. So a car is driving towards us. Okay, and here's the axle. I'm actually not sure if I should even draw the actual car. Let's make it like a derby car. Okay, did you guys ever do a derby car? When you're a little kid, it's a go-kart. So there you are. There's your chair. And you are just ready to go. This is you. You have I don't know what I'm drawing right here. Okay. There you are. That's better. There you are in your car, living large. So your tires are rotating like this, right, as you drive towards me. And they're rotating around this axis. Well, this axis is a medial lateral axis. Okay? And what I mean by that is really probably a better word. I'm sure there's a better word than medial lateral, but my point is, if this was anatomical position, this axis is moving from a medial origin and it's extending out laterally. And then the tire is spinning in the sagittal plane. Okay, this is the same as flexion and extension. That might not be helpful yet, but let me do one of these for each. So abduction adduction would be a airplane. All right, so here's a little, why can I draw a circle? Okay, there's a circle. And then here's the propeller. I wouldn't fly that plane if I were you. All right, there, let's give it like a little character. It's got like some wings turn up. It's got a fin. Okay, now we're talking. Anyway, so that propeller is spinning in the frontal plane, right? The motion of the propeller is occurring in the frontal plane, and the axis is anterior posterior. I'm looking straight at one end of the axis. So the propeller spins around an anterior posterior axis in the frontal plane. This would be abduction and adduction. And then lastly, we have oh boy, let's see if we can do this, you guys. Ooh, yeah. Drawing 3D. Any guesses? Oh, that is a good looking helicopter, if I do say so myself. There you are. Just excited to be learning anatomy. I don't really know how to draw a steering wheel. There we go. Here you are, totally unnecessary detail. And let's not forget the most important part, a smile. And there you are flying a helicopter, and your rotor is spinning in a transverse plane, like picture a tabletop, that'd be the transverse plane, around a superior-inferior axis. The axis is going from superior to inferior, or inferior to superior. All right, and that would be horizontal abduction and adduction. So I'm not sure if that helped or worsened, but there you have it. I'll try to talk about motions as much as I can throughout the remainder of the lecture. And then the last one is circumduction. This one occurs around multiple axes. So let's pretend you're sticking your arm out like this. Again, important part, kind of creepy. Here's your hand. Okay, so you have a few extra fingers there. And let's say you're now outlining a cone in space. Right? So you're kind of spinning your arm around. Like picture you're turning a steering wheel like multiple times. You're drawing a cone in space, so that's called circumduction. There's only two joints that can do that, and it's your shoulders and your hips because they're ball and socket joints. All right, good job. So now let's look at rotation. Lots of different joints can do rotation. So here I am. You know what? Probably the best way to do this would be to do it not in anatomical position. Normally I'd be with you in person and I could just show you an anatomical position and it would make so much sense, hopefully. So there you are, you're kind of falling forward. I didn't mean to do that. And now you've wound up and you're throwing a baseball, you're a pitcher. There you are, and you're mad. That kind of looks like a smile. It's a snarl. You're angry. You've got the eye of the tiger. You're pitching at the batter, and here you are. So when you wind up, you're rotating your humerus, right? You're rotating your shoulders. You wind up, or picture throwing a football or something. That's external rotation. And then as you throw it and turn your humerus, the head of your humerus medially, that's internal rotation. So your hip does this as well. Picture sitting cross-legged. As you go to sit down cross-legged, you externally rotate your hips. If you've ever sat, like, it's called W sitting, where kids do it all the time, where you kind of like turn your knees in and stick your legs out and sort of sit down. That'd be internal rotation. Really throwing is the best thing that I can think of, though, for internal and external rotation of your shoulder. Anyway, so rotating, I'm so sorry, you guys, I gotta delete these yawns. Rotating the head of the humerus medially is called internal rotation. And I say humerus, but it could be the femur, it could be the radius. Rotating the head of the humerus laterally is external rotation. And then this would occur around the superior inferior axis, just like horizontal abduction and adduction. Then we have some special movements that are going to be very difficult to describe. I'll probably post a second video, or a couple videos explaining some of these. But supination, if you picture opening, picture a door with the doorknob on the right, and you grab the doorknob with your right hand, and you turn the doorknob to the left, counterclockwise. That's pronation. You're turning your palm's probably facing up when you grab the doorknob, and then you're turning it over to turn the doorknob to the left. That's pronation. Turning your palm up is supination. So I kind of picture turning my palms up and putting them together like you were going to let them fill with water to wash your face. Those are two supinated forearms. And then if you were to put your palms down, like rotate them down and get into a push-up position, that's almost kind of like you can picture your hands being pronated. So it's just turning your palms up is supination, turning them down is pronation. Dorsiflexion and plantar flexion is a little bit easier to describe. Four toes? No. Okay, so here's your foot. Oh boy, that's ugly. Okay, so there, oh man, you're a duck, you're part duck. All right, so here's your foot, it's on a gas pedal, a big gas pedal. And now you're going to push the gas pedal down. Now in real life, you're using your knees and your hips and stuff, but just pretend we can only move our ankle, okay? So if we're rotating our ankle down like this, that's ugly, to push the gas pedal down, that's plantar flexion. And then lifting it up is dorsiflexion. So kind of letting your, if you picture standing up on your tiptoes, that's plantar flexion, and then dorsiflexion would be like lifting your you're actually flexing your ankle up. They get the name because the top of the foot is called the dorsum and the bottom of the foot is called the plantar surface, so it's dorsiflexion and plantar flexion. Inversion and eversion is much harder to draw, but inversion is turning the sole of your foot in. Like if you picture you had to climb a palm tree, you might kind of turn your soles in to get a better grip. I spent some time in Haiti, and it's amazing, like different flexibility that they have that I don't like. They just had a ton of inversion because oftentimes they're not wearing shoes, so their feet have to be a little bit more dexterous than ours. But anyway, so turning the soles in is inversion, turning them out is eversion. Most people don't have much eversion. It's hard to turn the sole of your foot out, but there's a little bit. Protraction and retraction, there's different. This could apply to many different joints. You can protract your scapulae. You can protract your head. I think the easiest one to describe is your jaw. So if you picture sticking your jaw out, like Marlon Brando from The Godfather, or just picture a bulldog with an underbite, that's protraction. And then bringing your jaw back is retraction. Elevation and depression. This could be your mouth. Opening your mouth is depression of your mandible, and closing it is elevation. If you picture shrugging your shoulders, that's shoulder elevation, or relaxing them, that's shoulder depression. And then opposition is a cool one. This is because our thumb is rotated 90 degrees away from our other fingers, you can actually touch the pads of your fingers to your thumb, each one. And that's called opposition because you're opposing your thumb and another finger. You can't do that with any of your other fingers. You can't oppose your middle finger and your index finger. It doesn't work, but you can do it with your thumb. This slide I'm going to do a really short separate video for. I'll call it types of synovial joints, and we'll just explain these different types and provide examples of each. I'm going to ask a lot of quiz questions from that video, so I'll have that posted as soon as I can. This is a quick check your understanding. So imagine for a second, here you are, you've got your socks on. I was going to say shoes, but they look like socks now. Here you go. Oh, I should have just drawn one leg. Oh well, there you are. And here you are, you're walking down the street, minding your own business, and what do you know? There's a dime. Goodness gracious. So what do? Well, your ankles are going to dorsiflex, your knees are going to flex, your hip is going to flex, and then you're going to reach down and you're going to, oh, you're still a little too short. Reach, there you go, fingers. So your hips flex, your knees flex, and your ankles plantar flex. And then when you stand up, your hips extend, your knee extends, and your ankle plantar flexes. All right, so now we're going to take a look at some specific synovial joints. Of course, there are a ton of synovial joints, especially in your limbs, but all over your body. We're just going to look at a few of them, starting with the knee. So the knee joint, and the word joint is in quotes here because it's actually a collection of three joints. The patellofemoral joint, which is the joint between the patella and the patellar surface on the femur. And then we have the tibiofemoral joint, which is kind of what you think of when you say knee joint. This is really the joint you're thinking of typically. And it's just this joint between these tibial plateaus and the femoral condyles. So when you extend and flex your knee, that motion is occurring here. And then the patella is always along for the ride as well. And then we have the proximal Tib-Fib joint. Right here, you have a proximal and a distal Tib-Fib joint. It doesn't partake much in the motion that occurs here. There's not much movement. There is some, but there's not much movement occurring here. So really quick, the articular partners for the patellofemoral joint are the facets of the patella and the patellar surface of the femur. For the Tib-Fib joint, for the tibiofemoral joint, it's the tibial plateaus and the femoral condyles. And for the proximal tibiofibular joint, it's a tibial and fibular facet of the fibula and tibia. So the knee has two really impressive, whoa, there's a crack in my desk and my mouse went crazy. It has two really impressive menisci. So if that's the tibial tuberosity, whoa, I got a little carried away there. I meant to draw the medial plateau bigger, but not that much bigger. Anyway, so we have our intercondylar eminence, or tubercles here. Oops, and that's not how they look. They go this way. The medial meniscus is bigger, and it's more C-shaped. It kind of probably look more like that. And then the lateral meniscus is smaller, and it's O-shaped. That's a bad drawing. bear with me. Anyway, I just wanted you to see them. They sit in between the articular surfaces of the femoral condyles and the tibial plateau. So they take a beating. They absorb a lot of shock, and they're subject to a lot of compression and shear forces all day, every day. So they're pretty remarkable structures. We have a couple ligaments here that I want to talk about. Let's do MCL and LCL first. These ligaments exist outside of the joint capsule, so they're called extracapsular ligaments, and they're called the medial collateral ligament and the lateral collateral ligament. The lateral collateral ligament is easy to see right here. You can actually feel it if you're on the skinnier side. I can't feel mine, unfortunately. There was a time. Anyway, so it's kind of on that lateral side of your knee, and it feels like a pencil in between your lateral femoral condyle and your fibular head. Medial, you can't feel because it's more fan-shaped, and of course we can't really see it from this angle, but it covers the whole medial condyle and medial condyle of the tibia and femur both, and it's more fan-shaped. That can be torn, I shouldn't say easily, but it's a pretty common injury, oftentimes alongside a medial meniscus tear and an ACL tear, which is referred to as the unhappy triad. It's kind of outside of the scope of this class, but really quick, if you picture your, your feet here, there they are, and then your hips are wider than your knees, right? So they kind of come in like that. And so the wider your hips, basically, the smaller this Q angle becomes here, and it places some stress on the knee. It's called genovalgum. So it's a valgus stress. Anyway, the point of telling you that is oftentimes people who tear their ACL, MCL, medial meniscus are often women playing sports where there's a jumping and landing, like basketball or volleyball. It can be torn any number of ways, and certain activities are more likely to tear the ACL versus the MCL. But that whole unhappy triad idea where all three tear, it's typically a landing injury. And it's typically in women for this reason, because their Q angles are larger. And it just causes some rotary and adduction stress at the knee, and it can cause that. That can also stem from weak glute musculature, although not necessarily, or just a kind of improper coordination of the way you absorb ground reaction forces from a landing. A quick test you can do on somebody is to have them step up on a step or a box and have them jump off. And if they flex at the waist and at the knees, and their knees don't go way far over their toes, and they don't buckle, but rather they absorb the force through their hip and knee evenly, they're probably pretty safe from that type of injury. But if their knees collapse, or if their knees go way over their toes, they may even fall forward. That's kind of a bad sign, or it's a predisposing factor for this kind of injury. Anyway, I got way off track there, I'm sorry. So the LCL's on the lateral side, the MCL's on the medial side. Now I want to talk about the ACL and the PCL. So here is my attempt at a lateral view of the knee, and I'm going to make the joint cavity huge because I want to be able to draw on there. So there's the tibial tuberosity, anterior border. Oh boy, Not the prettiest thing I've ever seen, but, and there's the patella. This is a right knee. Fibula would be in here, of course, right? Somewhere in here, going down, but it's not super important. We'll just leave it at that. So let's talk about the ACL and PCL. You've probably heard of these ligaments. They form a cross when viewed laterally or medially, when viewed from the side. So they have the name anterior cruciate and posterior cruciate ligament. The anterior cruciate ligament and the posterior cruciate ligament are named for their attachment on the tibia. So the ACL attaches anteriorly on the tibia and posteriorly on the femur. The PCL attaches posteriorly on the tibia and anteriorly on the femur. Now, these are really important for rotary stability, which is why oftentimes a landing injury can tear them. They also resist anterior and posterior translation, and that's easier to explain, so we'll stick with that. But know that they also resist rotary torsion at the knee. So anyway, let's do the ACL first. So it attaches anteriorly on the tibia. So it's going to prevent the tibia from doing that. Can you imagine that? If you look at it, you can picture how it's not going to let the tibia move forward. It's also not going to let the femur move backward. So another way of saying that would be that the ACL prevents anterior translation of the tibia on the femur, and it prevents posterior translation of the femur on the tibia. There should be a line through that because it doesn't let the femur move back. So that's the ACL, and that's kind of handy because the anterior cruciate ligament attaches anteriorly on the tibia, and it doesn't let the tibia move anteriorly. So it's AAA, it kind of all goes together in reference to the tibia, and then you just need to remember to flip-flop it for the femur. The PCL, of course, is just going to be the reverse of that. So it's going to prevent posterior translation of the tibia, and it's going to prevent anterior translation of the femur. So the posterior cruciate ligament attaches posteriorly on the tibia and prevents posterior translation of the tibia. So it kind of all fits. Hopefully that wasn't too crazy confusing there, but anyway, those are two important knee ligaments. There are, of course, more ligaments, and there's tons of muscular tendinous support as well. This is just a quick little snapshot at the knee. Please write down that the knee is a modified hinge joint. It's almost a pure hinge joint like the elbow. If you picture the elbow, it flexes and extends, that's it. Just like a door opens and closes, the elbow flexes and extends. It can perform two motions, and it can move around one axis. It's a uniaxial joint. The knee is kind of weird because it's like the elbow. It's actually kind of the counterpart of the elbow. It's the elbow of your leg, right? It's in between your thigh and your femur and your tibia, just like the elbow's in between your humerus and your radius and ulna. But it's a little bit different because the knee can rotate. The tibia can actually rotate medially and laterally slightly on the femur, and that's easy to do if you sit down in a chair. So your knee's bent, you can move your toes left and right. You can rotate on your heel. That's not coming from your hip, of course, because your knees are bent. So it's coming from your knee. So we call the knee a modified hinge joint. It's a little bit more, it's a little fancier than the elbow. It can do a little bit more. The shoulder. So the shoulder joint is in quotes again because it's actually a handful of joints. The one we're really typically thinking of is the glenohumeral joint, which is the joint between the head of the humerus and the glenoid fossa. Most of your shoulder motion comes from that joint. Your AC joint is just sort of a passenger here. It's the connection between your acromion and your acromial facet on your clavicle. Then you have your SC joint, which isn't in this picture, but if we continued the clavicle over, eventually it would attach to the manubrium at the clavicular facet. If you can kind of visualize that. It actually turned out okay. Also, there's one more I want you to add here, right in scapulothoracic joint. It's not a true joint, so put that. Just put scapulothoracic and maybe put joint in quotes. It's not a joint. The thing is, though, a lot of shoulder motion occurs at this quote-unquote joint. And that is, we're addressing the fact that this subscapular fossa here which is filled with subscapularis in your body. There's a muscle there. That surface is gliding over your ribs when you move your shoulder. And actually, when you get to about 120 degrees of flexion or abduction, so this motion, if we were doing a snow angel and we're lifting our humerus up, once we get to 120 degrees, we're out of motion. But I'm sure you can all reach your hand much higher. You can stick your hand straight up in the air. That motion occurs from this joint. Your scapula actually upwardly rotates for that last 60 degrees of motion. So a lot of motion occurs at this joint, so I feel weird not including it, even though it's not truly a joint because there is no bone-on-bone articulation. Instead, your scapula is just sort of floating on top of the muscles of your ribs. So it's kind of an interesting design. There's no other joint like it. Continued here, we already talked about the articular surfaces. They're somewhat congruent. They're not nearly as congruent as the hip. I mean, if you look at the glenoid fossa, it's relatively small compared to this large humeral head, but nonetheless, it's pretty, it's fairly congruent. It fits together well. The shoulder benefits from a ton of ligamentous support. These are just a few examples. You have 1, 2, 3 glenohumeral ligaments on the front of the joint capsule. Those are capsular ligaments. And then you have this coracohumeral ligament right here, which is a ligament between the coracoid process and humeral head, not to mention coracoacromial, the tendon of biceps, the trapezoid and deltoid ligaments. There are just a whole bunch of ligaments. I won't be quizzing you on what the ligaments are. I do want you to know how much the shoulder relies on musculotendinous support, though. That is a big factor. Let's go back really quick. We can see, we can only see one of them here, but we have these muscles called the rotator cuff muscles, and the acronym for them is SITS. That's supraspinatus, infraspinatus, teres minor, and subscapularis. So here we can see supraspinatus on top, stabilizing the humerus. Subscapularis is in the front. So there's a muscle here that covers the front of it. And the teres minor and infraspinatus support it from the back. So the humeral head is just and that's just the rotator cuff. We have deltoids, pectoralis, latissimus, biceps. There's a ton more muscles, but the rotator cuff in particular really just keeps the humeral head in the glenoid fossa. That's why if you have a stroke, a lot of times your humeral head could slide out because all those muscles relax. So anyway, I just wanted you to know that the rotator cuff is a big stabilizing factor, as is the long head of biceps tendon, which you can see right here. This tendon is super interesting. It actually goes under these ligaments under the capsule and connects to not the coracoid process here, but behind it, the supraglenoid tubercle. And you can see how it would sort of support the head of the humerus anteriorly and superiorly. And it actually attaches to the glenoid labrum, which is a little ring of cartilage here that wraps all the way around, including the supraglenoid tubercle. And you can actually tear your glenoid labrum by an action that really strains your biceps. Interestingly enough, because we think of our biceps as an arm muscle, and a muscle that bends our elbow and supinates our forearm, but it actually affects the shoulder as well. Glenoid labrum is incredibly important, of course, but it is rather shallow in the shoulder. It's nothing like the labrum of your hip. And the shoulder has a very thin and loose joint capsule. So that's a weakness in terms of stability, but a strength in terms of mobility. It allows you to move your shoulder a lot. If this capsule was tighter and thicker, it would limit our motion. So now we're looking at the elbow. Again, joint is in quotes because it is 2, arguably 3 joints. So there's a joint here between the trochlea and trochlear notch. There's a joint here between the fovea and the capitulum. And I forgot to highlight the trochlea there. And then there's also a joint between the radius and the ulna. Now, when we're talking about the elbow, though, really, I think what we're talking about is this ulnohumeral joint. That's the joint that performs flexion and extension. These joints are more involved in pronation and supination of your forearm, Although there is some articulation here during flexion and extension too, of course, but we're really, when we're talking about the elbow, we're really talking about the ulnohumeral joint. So if you take a little deeper look at the ulnohumeral joint in particular, again, reminder, it is the trochlear notch and trochlea articulation. So as we flex our elbow, that trochlear notch is going to glide up onto the trochlea more here. And it is a very congruent structure. It's not easy to dislocate your elbow, but it certainly is doable, especially if you break your ulna. And that actually, something similar happened to my little brother snowboarding, but it is very congruent and has a ton of ligamentous support. Actually, you'll find that it's pretty similar to the way the knee is supported. It has a lateral, oh, we already did the knee. It has a lateral and a, I'm sorry, that's medial. It has a medial and a lateral collateral ligament, just like the knee, but we call them instead the ulnar collateral ligament and the radial collateral ligament. That supports the elbow from the sides. That makes sure your elbow is only doing flexion and extension. You don't want your elbow doing any abduction or adduction. That means you tore something and you're having a bad day. There's a great deal of musculotendinous support. We don't really need to go into it a ton, but just know brachialis, which is your main elbow flexor, crosses the front and attaches to the ulna. The biceps attach to the radius, this radial tuberosity in particular, right here. And then you have all of your forearm muscles on the side. You can't really see on the black background, but those attach to what's called the common extensor and flexor tendons. So the common flexor tendons on the medial side and the common extensor tendons on the lateral. So between all of this, not to mention your triceps posteriorly, the elbow's in a cage of tendons and muscle tissue. So it's a very, very strong joint. So next time if you're like me, you try to carry all the groceries up in one trip, don't worry, you're good to go. You can do like 30 bags in each hand, you'll be fine. That was a random thought, I'm sorry. So next we have the hip joint or coxal joint. This is the first joint that is actually one joint. And it's a heck of a joint. The femoroacetabular joint is a joint between the acetabulum, in particular the lunate surface of the acetabulum, and its articulation with the femoral head. Two very congruent structures. Here's a little kind of internal view here, and you can just see how much tissue-on-tissue contact there is between the two articular surfaces. Not to mention that, but I'm going to jump down here to the acetabular labrum. That labrum actually extends and is actually narrower than the maximum width of the femoral head. What that means is that femur is not coming out without tearing the acetabular labrum, and many ligaments and muscles potentially. That is one stable structure. It's the rare exception of a joint that is both mobile and stable. Basically, you've probably heard of these joints of people dislocating their hip, typically elderly people. Like you threw their hip out or dislocated their hip. That's typically going to be in someone who's had a hip replacement. So hip replacement is a pretty common procedure, and you have to cut the joint capsule, and the older procedures you even had to cut muscle and potentially the labrum, and so the hip, and then you're replacing the acetabulum and femoral head with two structures that aren't quite so stable. I mean, it's a metal prosthesis and a plastic cup, but it's not as stable even still as your actual femoral head and acetabulum is. So that's typically, when you hear about a joint dislocation, is typically in an older person or a very young person whose hips aren't fully formed. So anyway, ligamentous support, you have some of the biggest ligaments there are right here, sort of corkscrewing around the femoral neck, and that's so cool if you look at it, because you can imagine if you sat down, these would loosen up, right? Picture the femur coming towards you, it would be unwinding these ligaments. So when you're sitting in a chair, your hips are easier to move around. But then you stand up and it winds the ligaments up, it corkscrews it, and your femoral head just gets compressed even more forcefully into your acetabulum. So it's more stable and standing when you need it to be stable. There's also a ligament that actually attaches to the fovea capitis, right into the head of the femur. It's really just there to protect an artery, but it also increases stability. And then musculotendinous support. That's a no-brainer here. I mean, all of the biggest muscle groups are right here. So posteriorly, you have your glutes, and then medially, you have your adductors here, and there's a ton of adductors. I'm just kind of making it up here. And then you have your these were adductors, and you have your abductors. So the extensors posteriorly, abductors laterally, hip flexors, which are huge, powerful muscles in the front, and then adductors medially. So again, it's just this cage of the biggest muscles of your body. So very stable, very strong joint. Here's the TMJ. This is kind of the opposite of the hip. It's very, very mobile, but not stable at all. It's actually the easiest joint, I would say, to dislocate. So let's talk about it really quick. So it's composed of an articulation between the mandibular condyle and the mandibular fossa here, except that they don't actually touch one another because there's an articular disc in between. I'm just kind of putting black all over the place. Sorry, let me erase all that. So they're both sort of articulating with this articular disc. So it's almost like two joints stacked on top of each other. And if I was going to compare it to a joint in terms of structure, not in terms of stability by any means, but it's a lot like the knee. So if you imagined you cut the knee in the sagittal plane and you took one tibial plateau and one femoral condyle on either side of that cut and put them on either side of your face, that's kind of this joint. Because it is sort of a modified hinge joint, because it's primarily doing opening and closing of your mouth. But you can also stick your jaw out. You can laterally deviate it from side to side. So there's a lot of gliding that occurs too. And that's where things sort of get interesting because we have this articular tubercle right here. And then so what happens is the first 25 degrees or so of mouth opening occurs between this mandibular condyle and the articular disc. And that's all fine and good. It's pretty unlikely to dislocate your jaw just talking like I am right now. But then if you were to open your mouth wider for some reason, what happens is that this whole mandibular condyle actually slides forward. It slides forward and continues to rotate. So if you stick your pinky in your ear and kind of talk, you can feel this mandibular condyle, because here's your ear right here. You can feel this mandibular condyle moving. And then if you open your jaw really wide, you can kind of feel, if you're kind of feeling in front of your ear, you can kind of almost feel what's going on there. And so anyway, the first 25 degrees of opening is very simple rotation. Past that, you have this anterior gliding taking place. Anyway, so sometimes the condyle can slide off of this disc. And it's not like this traumatic thing, like in a movie where someone dislocates their shoulder or anything like that. You may not even notice it, but at some point it's going to probably, hopefully, slip back into place and you're going to hear your jaw click. And that clicking noise is the mandibular condyle sliding back onto the articular disc. So this is a joint that can dislocate and relocate regularly without, any cause for alarm or anything like that. It may have happened to you today. If you are having a lot of pain here and a lot of jaw clicking and you're a gum chewer, you probably want to stop that. It's also kind of a joke that maybe you talk a lot because it is a repetitive use issue as well. In addition to just maybe your TMJ is structured a little differently, it's a little bit easier to dislocate or whatever. But anyway, the point here is that this is an unstable joint. Despite having actually a ton of musculotendinous support. These are some big muscles, your masseter and temporalis at least. I think that's it for the TMJ. Check yourself. What is purely uniaxial? We're going to go into this more in that other video I promised, talking about the joint types. But let's just think about it. So your shoulder can do all kinds of stuff. It can do flexion, extension, abduction, adduction, internal rotation, external rotation, circumduction, horizontal adduction, horizontal abduction. So it can do all sorts of things around 3+ axes. So we would call it multi-axial. Your hip is the same design, so it can do all those same things as the shoulder. The TMJ, open and close, that's uniaxial, but it can also deviate from side to side and protrude. You can protrude and retract your mandible. So it's not that. What do we have left? We have the elbow. The elbow flexes and extends around a medial lateral axis. It has one axis, just like a door. That's why we call it a hinge joint. So your elbow is purely uniaxial. Which is most easily dislocated? That's your TMJ. Which are multiaxial? So your hip and shoulder are both multiaxial. We could say that your knee is biaxial. Your mandible's tougher to define because a lot of that movement is just gliding. But even so, I would say that it is maybe biaxial at best, or even uniaxial. It's a tough one, which is why I didn't call it uniaxial earlier. That's just your elbow. That's purely uniaxial. So just your hip and shoulder of the ones we discussed. Which is more mobile and therefore less stable, the glenohumeral joint or the hip? The shoulder is more mobile and therefore less stable. They're both stable, they're both mobile, but when comparing the two, the shoulder sacrifices some stability in exchange for mobility. Now we just have 2 slides left just to talk about joint injuries. So the cartilage tear is relatively self-explanatory. It's a tear in cartilage. This is no fun because cartilage does not have a great blood supply, especially fibrocartilage like a meniscus. But it's also not innervated, so it's not terribly painful, at least not at first. Typically kind of the telltale sign is some blocking or catching of a joint because that cartilage tear is getting kind of stuck and preventing fluid motion of the joint. And that can take some time to heal, potentially surgery depending on the severity. And then sprains, this is a ligament injury. So we could sprain this structure here. This is our ACL. You have the potential to sprain that. A strain is a muscle injury. A sprain is a ligament injury. If you've ever been walking and rolled your ankle, maybe you had a really minor sprain of your anterior talofibular ligament, which is kind of the typical ankle sprain. But of course, any ligament can be sprained, and it can have various degrees of a sprain and eventually a partial or full tear. A subluxation is just a minor dislocation. It's not a full dislocation. Some structures were damaged and something happened, but it didn't fully dislocate. Luxation is kind of the scientific term for a dislocation. So a subluxation is just a minor dislocation. And then lastly, we have 4 inflammatory disorders and potentially also degenerative disorders. So bursitis and tendinitis, these are fairly common. These are just overuse, repetitive activity type injuries. Picture, a contractor who's swinging a hammer all day. He could start to aggravate some of the tendons used to decelerate that hammer, or to wind that hammer up, like in the lateral aspect of his wrist, for example, or his elbow. And that's just inflammation of a bursa or a tendon. Very common. Rest is typically the best course, but there's certain exercises and things that can help, as well as just minor pain medications and things like that. Osteoarthritis, this is a fancy name for something that's pretty simple. It's just a use-related wear and tear disorder. So the older we get, the more likely this is to happen. And if you live long enough, you'll get it. By the time I think you're like 26, one of your joints is already slightly arthritic, which is a little depressing. So it's a disorder. I guess you could call it a disease. I feel kind of funny calling it a disease. It's like, imagine a 95-year-old and kind of picture what they might look like. And then imagine that same person at 20. Something's most likely happened to their face, let's say, and their appearance between the age of 20 and 95. But you would not, say that they had degenerative face disorder or facioitis, right? It's just an age-related process. And that's what osteoarthritis is. Although there are certain things that predispose you to OA, like your weight, and then how, your body mechanics, that sort of thing. So typically, if osteoarthritis becomes bad enough, you may be looking at a joint replacement like this individual here in his left knee. He's having a bad day there. There's a lot of bad stuff going on. He's heading towards a joint replacement for sure. But it's not really a disease process. Contrast that with rheumatoid arthritis, which is absolutely a disease in the traditional sense. It has a disease process. It's an autoimmune disease. Genetics may be involved as well, but it is an autoimmune disease. That's the mechanism. Your immune system begins to attack your own cells. And we have a cell designed to do that called a cytotoxic T cell, but it's only supposed to do that on cells that are infected with a virus or that are foreign to our body. But for whatever reason, in someone with rheumatoid arthritis, those cells are attacking our synovial membrane, And it can get so bad that it starts to attack the surrounding ligaments. So if you've ever met someone, it's most likely a grandma or a great-grandma that has her fingers kind of look like this. They have what's called ulnar drift. I know my grandma had this, my great-grandma. That's because the rheumatoid arthritis became so bad it starts to attack specifically the lateral collateral ligament of your metacarpophalangeal joints, which then causes your fingers to be pulled in an ulnar direction. This is incredibly painful. All of this, everything on this list is incredibly painful, but rheumatoid arthritis in particular is a very painful disease process. Eventually your body will just fuse that joint because the inflammation has gone on for so long and the pain has gone on for so long, your body will actually just ossify that joint. So this is the one you definitely don't want to get out of the 4, although you'd probably like to avoid all of them. This is most commonly diagnosed in a 30 to 50-year-old female. It's actually pretty rare in men, and it's pretty rare later than 50 or earlier than 30. And let me clarify that. It's rare to be diagnosed later than 50. You'll meet plenty of 50, 60, 70, 80, 90-year-olds that have rheumatoid arthritis, but it most likely started in their 30s or 40s. And they may not have had it diagnosed until later, but that's typically when the disease process begins. So, you might see a question on your test that says you are reading a patient's chart and it indicates that they have rheumatoid arthritis. They were just diagnosed last week. What kind of person are you expecting to see in the waiting room? An 80-year-old man, a 40-year-old female, or a 17-year-old boy. And you would say the 40-year-old female, because the profile of the disease kind of fits that description. And that's the only time you can profile healthcare and if you're an FBI agent. But other than that, you shouldn't do it. Gouty arthritis is our last one here. And although this one's incredibly painful, it's probably one of the better ones to find yourself with because it is so treatable. But basically, for whatever reason, your body is not secreting enough nitrogen waste. You're not secreting enough uric acid in your urine or sweat or whatever, or you're bringing too much in, which is the more common issue. And this is diet related. It can be genetic. It can be unrelated to diet, but typically it's diet related, and it can be related to alcohol consumption, meat consumption, particularly organ meats, anything rich in nitrogen waste. And basically that urea, that uric acid in your blood forms crystals inside of your joint like little needles, and it actually hurts really, really bad. And it's most common in the base of your big toe. So if someone has gout, it's typically, they're talking about foot pain. And they say it feels like I'm stepping on needles because they kind of are. It's kind of what they're doing. So fortunately, there's, you can change your diet. There's certain medications that can resolve this. And guys, that's it. We have our 4 inflammatory disorders, three types of arthritis. There are more types of arthritis, like juvenile idiopathic arthritis, psoriatic arthritis. We're just covering these 3 here, as well as bursitis and tendinitis. And that is it. I will post a couple more videos. Oh, you know what, real quick. What does arthritis mean? Joint inflammation. How would you guess by looking at someone, whether they have OA or RA? OA is mostly age-related and use-related. RA, we're expecting a female, number 1, and we're expecting their onset date to be in their 30s or 40s. All right, guys. Thank you.